We are live. Great. And we are live again. And welcome back to another episode of Machine Medicine's podcast on neuromodulation, past and future. And we're delighted this week to have Dr. Vibhor Krishna, who's an associate professor at the University of North Carolina at Chapel Hill, as well as being a busy neurosurgeon and a clinician scientist. Is that right, Vibhor? We're delighted to have you, and it'd be great to hear a little bit about the trajectory that brought you to this interesting field of work.
Thank you, Jonathan. It's good to be here. And yes, you're right. I'm a surgeon scientist. I specialize in stereotactic and functional neurosurgery. And we use electrical stimulation, focused ablation in different therapeutic areas of brain, spinal cord, peripheral nerves, to improve patient symptoms, improve their quality of life. And we treat patients who have movement disorders like Parkinson's disease, essential tremor, neuropathic pain, patients who have epilepsy, patients with different psychiatric disorders as well.
Great. And how did you yourself get to come into this field? Was it something you always planned, or how did it come about?
So during my residency, I attended different cases, and during my interactions with my mentor, Dr. Steve Tackage, I saw the promise of neuromodulation and the impact it had on patients and their lives. Saw how patients with Parkinson's disease were able to function better. Patients with tremor, their tremors improved. The most profound moment, though, we had was during a trial that was being conducted in patients with treatment-resistant depression. And the target was a cortical-based target for improving patients' mood. And during intraoperative stimulation, the patient had profound changes in their symptoms, and they spontaneously mentioned that now they were able to see colors that they couldn't see before. That really piqued my interest into really understanding how stimulation in different brain regions changes the network dynamics to bring about improvement in patient symptoms.
Right. Fascinating. So it was basically, you entered medical school with a fairly open mind, but then by the time you were getting towards finalizing your training, you'd seen enough impressive work in neuromodulation. You thought this was the right area for you, and it sounds like it was basically the therapeutic potential of this. Correct me if I'm wrong, but it seems like neurology's always had a bit of a reputation for being a chiefly diagnostic and prognostic specialty, and maybe neurosurgery as a kind of sort of damage limitation exercise. But now this is really a sort of a very powerful therapeutic sort of platform that's being developed in each of these cases: high frequency ultrasound, electrical stimulation, even magnetic and other forms. Would you agree with that?
Yeah, that's a astute observation. Traditionally, neurology and neurosurgery were mainly involved in diagnosing the patient with the correct disorder, and we had limited treatment options to be able to address. And you're right, in some sense, the main goal for us in neurosurgery was to prevent any further decline, to keep the patient safe, and do as much as we could to improve their quality of life. With neuromodulation, we are moving into a space where the traditional diagnostic modality, which we relied mainly on MRI, essentially doesn't reveal the pathology inside the brain. And so if you look at the MRI of a patient who has Parkinson's disease, it looks very similar to someone who is of their age and gender who don't have Parkinson's disease. And so then the idea becomes, how do you identify, correctly who these patients are who have the disorder, and patients who are appropriate for this treatment. And then take the next step and say, given this presentation, what therapeutic area in the brain would be most appropriate for this patient. And so in some sense, this specialty of neuromodulation transcends the traditional boundaries of neurology and neurosurgery, and it requires a multidisciplinary approach where neurologists, neurosurgeons, psychiatrists, psychologists all collaborate together to really characterize the disease process, identify patients who are who are most likely to benefit from these interventions, and then undertake a targeted intervention and improve patient symptoms.
Yeah, and when you're asked to define neuromodulation, how do you typically go about doing it, just to try and sort of crystallize the concept for people?
So in my mind, neuromodulation involves targeted intervention, which could either be electrical stimulation, which could either be ablation, which could be targeted drug delivery, to bring about a restoration of network dynamics in the brain. So in patients who have different disorders, we come to understand that the brain networks sometimes are not properly functioning at their physiological levels. One way to improve patients' lives would be to go back and sort of reverse the pathology, and that would in turn bring about a normalization of the brain networks. Another way to look at in neuromodulation space is to say, given the disease pathology, there are certain changes, abnormal changes in the network dynamics. And what can we do in this current state with our interventions to restore the physiology without reversing the underlying disease pathology? There are still challenges that remain in restoring the brain structure and function in patients who have different disorders. And so given that we have a diseased brain, what interventions can be done to restore brain networks is what neuromodulation is.
And of course, these pathological processes can take all kinds of forms. I mean, for example, the evidence on the genetic drivers behind depression, it seems to be that there's certainly a very strong heritable component. So if we were reversing the disease process, we'd actually be talking about editing the genome, or at least intervening at some level where the genome was being translated into network characteristics, right? So in some of these situations, it's very hard to imagine how this could be done, post sort of conception and development of the organism. But that's a very interesting as a sort of general overview. It might be cool to focus in a little bit on one of your, I know you have an interest in neuromodulation in general, but one area where you seem to have focused, no pun intended, is in high frequency ultrasound. Do you want to say a little bit about what's special about this modality and why you're particularly interested in it?
So focused ultrasound is an emerging treatment for neurological disorders. It's FDA approved for treatment of essential tremor, Parkinson's disease, tremor-dominant Parkinson's disease. And what's exciting about this treatment is that you could ablate very precisely specific areas in the brain to restore the network dynamics. And this could be done without a surgical intervention, without opening the skin or drilling a hole in the skull. In fact, you actually don't even touch patient's head during the intervention. And so the idea of focused ultrasound derives from some of the concepts in radiosurgery. But this time, we have a ultrasound transducer, which looks like a helmet. It's a hemispherical array. And there are 1,000 or so different elements, transducer elements, that are organized in this helmet. And these transducer elements are confocal at a single point in the center of the helmet. And by itself, the ultrasound energy that's delivered by the elements is not sufficient enough to perturb the brain structure or function. But then when 1,000 of these elements combine together at a single spot, you could achieve energy levels that can do a variety of different things. And so ultrasounds can be used to ablate inside the brain, which is the most advanced clinical application. Or they could be used to open blood-brain barrier and deliver therapeutics in very precise locations. And these could also be used to do neuromodulation, so non-invasive neuromodulation, which depends sometimes on temperature-based neuromodulation, thermal neuromodulation, or even without increase in temperature, you can modulate the function of nervous system with ultrasound.
So the principle is very similar to what some people may have come across in radiotherapy, where, for example, several different beams can be, as you say, confocally directed at, say, a tumor or something, to so that the energy levels at that point reach something much greater than they would in any of the other areas. So, and then it's interesting, so that you're actually performing a kind of you are performing an ablation of probably millions of neurons, right? In these, how big are these lesions? Millimeters?
Yeah, so these lesions roughly are 4 millimeter by 6 by 8 millimeters, sub-centimeter lesions.
Yeah, got you. So yeah, fairly small lesions, but substantial enough to have a therapeutic effect, and indeed substantial enough to have deleterious side effects in some cases, right?
Yes, and so if you keep the ablation precisely in the specific location that's supposed to give you therapeutic effect, then it could improve patient symptoms. As you rightly pointed out, if this ablation were to spill over into adjacent areas, it could give you side effects as well, because a lot of functions are packed together closely in the brain.
Yeah, absolutely. And this is I know we call it an ablation, but another word for it would be a small stroke, right? Kind of a thing in terms of its effect. And it's very interesting to try and just turn the clock back a little bit and try and understand how these animal studies, how were these? They must have then been translated into human studies. How were the standard targets first identified, and how much variability is there in the number of different targets? Say for essential tremor, is there consensus on the best target, or are there several sites? Much like you probably, I'm sure you're no doubt familiar with the debate in DBS about GPI versus STN and different patients maybe. So is there an equivalent debate in this area of focal ultrasound?
Yeah, so both great questions. And so if you were to look at the history of focused ultrasound, this was a concept that was tested in 1960s by Fry brothers with the idea that you could ablate inside the brain, again, using ultrasound beams. But at that time, it required you to do craniotomy, and so you had to remove pieces of skull to be able to simply do ablation. And so that idea did not catch attention over time. The inflection point in the journey happened in 1990s when Kalero Heinonen and his colleagues really figured out ways to understand the transmission of ultrasound through the skull and precisely do a correction in the phase of ultrasounds once it passed through the skull. And so the algorithms to really deliver ultrasounds precisely were developed in that time.
Fascinating. So were those physicists then, or engineers? So is that that sounds like a nice example of the different disciplines kind of contributing?
Yeah, so these were multidisciplinary teams.
Mm.
Physicists prominently contributed, engineers contributed, clinicians contributed to bring about a working prototype that could be then paired with the power of MR imaging and combine the two technologies together. You could precisely know what you're doing in the brain and then be very precise about it. And so that's where ultrasound finds its roots.
Gotcha. And the variables and the most important variables that you need to be able to monitor, would they be what, location and temperature? And these are things that you're able to do with the MRI and this improved modeling. Is that right? Are there other sort of crucial? I know there's multiple other variables that matter, but in terms of the sort of fundamental ones that really count.
You're absolutely right. The two fundamental sort of feedback or variables that are monitored during the treatment is location using the MRI, imaging, and then temperature monitoring. And so you could precisely in real time monitor a temperature rise, and based on the thermodynamic equations, you could say a temperature rise of so many centigrades for so many seconds could bring about ablation in the brain. So based on that approach, then you could precisely choose your targets in the brain and ablate those areas. And so the other factors, as you mentioned, that could be of interest include skull, because skull is the major impediment in the delivery of ultrasound. And certain skulls are more favorable for ultrasound delivery and others that are not.
Yeah, so I came across this. So, and basically, it's skull density. Is it? That's the important issue. Is that right, or is it the shape a factor too? Well,
you're right. And so, when you look at the skull, several other factors can come into picture. The thickness of the skull, right? We understand now that it's the variability in the organization,
right,
is important, and then shape is also important because ultrasound, if they were to be incident on the skull perpendicular, they are most efficient to go through. But if they have a certain angle and if that angle continues to increase, then the chances that the ultrasound will pass through reduces.
Gotcha. And so we talked about how this is a sort of targeted ablation, but another, if I understood, another interesting aspect of it is by being able to control the temperature, or more, at least monitor it and actually control it thanks to that good monitoring. You needn't immediately cause an ablation. You can raise the temperature and cause a temporary impairment of function. Is that right?
You're absolutely right. And so the application to functional neurosurgery becomes very exciting when you could control the amount of ultrasound that you could deliver. And so as you rightly described, initially you deliver only small dosage while monitoring the temperature and making sure you don't go beyond a certain threshold where the tissue changes could be permanent. And so you keep it below the thresholds so that you could reversibly heat up the tissue. And that could allow you to, in a limited way, interrogate your targets and understand whether a permanent ablation of this target would give you the symptom relief that you're looking for, or would it cause you to have side effects? Because if you are off target, that it could have side effects as well. And so there is a possibility for course correction before you make your ablation permanent. And so that's what makes it exciting for functional neurosurgery.
Right. Yeah. So you might think you're on target on the basis of your imaging, but then you raise the temperature at your putative target, and you find that actually you induce some side effect, like what are most typical, ataxia or some dysarthria or something like that, and then you can adjust it on the basis of those clinical signs and maybe move more medially or whatever the appropriate anatomical adjustment is, and then try again and sort of by a sort of process of trial and error find the right spot. Is that right?
Yeah, you're absolutely right. And so based on standard imaging, you have a very good sense of what the specific target would look like in most of the patients. But then, as we know that all of us have uniqueness to our brain anatomy, and so taking that sort of average information, then you say, if I were to interrogate this area, is the patient having any side effects? And as you rightly mentioned, depending on what side effect you notice, you could make specific moves in certain directions. And so if the patient is having weakness, when we do the ablation for tremor, then we move the target more medially. If they're having sensory changes, we move the target more anteriorly. If patient is having ataxia, then we move the target more superiorly. So there are guidance available based on what you observe clinically to perfect your target.
Very interesting. And you mentioned several times you talked about anatomical variation, which is no doubt hugely important for the reasons that you said. You mentioned several times the phrase of cortical dynamics, which is kind of the underlying mechanism here that's driving both the symptoms and symptom relief. Is there any way to get a handle on that yet? Can you characterize a patient's individual anatomy to some extent with MRI and more sophisticated approaches such as sort of anatomical tract delineation through MRI. But is there any sort of use of, say, EEG or any other sort of high temporal measurement tool that can give you a handle on the actual neurodynamics at the moment, or we're not quite there yet?
That's a great question, and so to unpack that, there are several groups around the world that are working on understanding the specific brain anatomy relevant to say tremor treatment or Parkinson's disease treatment, and delineate how the organization of brain is and where are the specific areas that would have therapeutic significance in patient's brain. Use the term tractography. That's the most commonly used to lay out the organization of brain tracts and optimize targeting so that you reduce the risk of side effects and maximize patient's potential for recovery. And then the other exciting areas, as you mentioned, would be that in real time you can study the dynamics in different brain areas and take that into account to optimize your treatment delivery. Again, several groups are looking at what signals can be of interest or creating, in some sense, a closed loop where you study an abnormal dynamic and use that information to titrate your treatment parameters. And so that's the future. That's what people are looking at.
People are trying to do at the moment. Yeah. And one of the things that struck me about something as simple as one of the conditions that this is effective for is essential tremor, and a very as a very common condition, right, affecting some integer percentage of the population. And really, I think people often, non-medical people and or not exclusively, but often fail to grasp, unless they have a tremor themselves, how debilitating it can be, right? But one of the things I found fascinating when I started looking at some of the physiological literature around here is how extensive the network dysfunction is. If I understood it, it even seems to extend from these cortical basal regions, but then also extending into the cerebellum, and so this network is really very, very extensive, at least on average, right? And how much variability is there in that? Do you have an idea of that?
Yeah, you're right. The network that is involved in essential tremor, the pathogenesis of essential tremor, is quite extensive and involves areas in the cerebellum, brainstem, thalamus, and of course cortex, cerebral cortex. And so it's widely sort of distributed network. And now the question becomes whether different tremor syndromes have different network dynamics and have a handle on that. And so again, that's an area of active research and investigation where we know that patients who present with action and posture tremor may not have the same syndrome, right? And so there is increasing recognition that the broader bucket of patients with essential tremor may have specific syndromes within those. We are not there yet where we could get a readout of the network state and network function, and sort of that could help us characterize and classify patients in different syndromes yet. We're not at that point yet, but that's where definitely the field is headed towards.
Yeah, and some of your work has been on trying to identify those predictors, right, of patient outcome. So how much success are we having, and what do you think the big opportunities for sort of improvement are?
So again, a good question. We wanted to know, who are the patients who are at the maximum likelihood of improvement. And so in some of the work, we understand that patients who are younger patients who have shorter disease duration are the ones who seem to have better outcomes than older patients with more severe disease. Then we noticed that there are some technique-related factors that are as well. And so during a treatment, if you are able to increase the temperature to therapeutic levels, 55 or more degrees centigrade or more, that was associated with better outcomes than treatments where this temperature threshold was not achieved. And this makes sense. If you were to ablate the tissue, you want it to be fully ablated, right? You wouldn't want it to be partially ablated. And then there are factors, that again are technique related, that the less number of total treatments or sonications that you can deliver to achieve the desired effect, the better it is. And some of it again comes back to how the skull behaves when it has been exposed too many times to ultrasound, and sometimes lead to distortion of the focus of the treatment. And so then moving forward, what we are looking at and investigating as a part of our research program is to figure out ways to optimize this treatment where you could achieve this in least number of sonications and improve the safety of this treatment, improve the effectiveness of this treatment by leveraging advances in neuroimaging, where we bring in information from tractography that allow us to have patient-specific maps to identify these specific therapeutic areas, and also use advanced imaging with diffusion MRI to characterize the tissue response in real time and see what part of tissue is permanently ablated and what part we can still work on to achieve further ablation.
So it's a sort of combination of multimodal kind of data sources and learning how to bring them together and turn that into a sort of functional understanding of the pathology and the patient.
That's
so a lot of work to do for the future. I'm conscious of time, and I did promise to let you go just after 1:15 to get back to your busy day. But what would we talked about what a sort of multidisciplinary project this is. What would you recommend to young clinicians sort of starting out in their journey? What skills should they be trying to acquire? What should they be getting trained in order to supplement the sort of the pure clinical thing? Because it sounds like there's so much opportunity here for ancillary skill sets such as coding or mathematical training. What's the most useful sort of arrow to have in your quiver?
Yeah, so this is a great question, Jonathan, and I've been thinking about this more and more lately. The training that we have within the traditionally defined disciplines definitely helps us to deliver care to patients to improve their lives. As we move forward, though, we would definitely need training which is transdisciplinary, where clinicians are trained again, say neuroimaging diagnosis, as you mentioned, coding, and then be engaged in testing and optimizing some of the techniques, and really understand what's the relevance of these techniques for clinical care. In order for us to have a translation from all the knowledge that's generated in neuroscience research, we need people who are at that intersection, who are trained in multiple disciplines and allow us to look at some of these emerging, scientific directions and really understand how they apply to clinical medicine, clinical neuroscience, and what can be done to really improve it, so that we are able to continue to grow the patient base and then be able to deliver care to some of these patients who currently don't have treatment options.
Yeah. It's a good thought, and I sometimes wonder if the time isn't ripe for a new clinical specialty to emerge, which would be something like computational physicians or computational surgeons or something like this, people who were essentially dual trained in the relevant engineering and clinical work. Although, as you'll be aware, it takes so long to train as a doctor and so long to train as a engineer. It seems somehow, this will always remain a multidisciplinary team. We just have to learn how to work with other specialists and how to talk to each other, even if we can't be completely fluent in each other's languages.
Absolutely. And at the level of organizations, I think leaders in healthcare should think about sort of bringing these different streams together, sort of, for lack of a better word, housing them together so that ideas and discussions to be able to make that transformation for future.
Yeah, absolutely. All right. Well, Vibhor, just remains for me to say thank you very much for your time and your and some insights into your fascinating work and that of your colleagues, and we'll watch with interest your future contributions and hope to talk to you again sometime soon.
Thank you, Jonathan. It was great to be here and discuss some of these exciting things.
Cheers.